Okay, hello and welcome to the Mathematics for Public Health Colloquium. I'd like to take this opportunity to acknowledge that the land on which the Fields Institute operates for thousands of years has been the traditional land of the Huron-Wendat, the Seneca and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. I would now like to hand you over to Professor Jianhong Wu, who's Principal Investigator for this program.
Good day. So I'm very glad David, Dr. Champredon is with us again. The Fields Institute. This is not his first time appearing in the Fields events, and even a year ago when Fields started its medical program, which including component of modeling the wastewater. David was a mentor and spoke to the young generation as well. So David, Dr. Champredon is a senior scientist with our Public Health Agency of Canada, and his expertise in modeling infectious disease in general, to respiratory infections and sexually transmitted diseases in particular. David is a main force both behind the screen and in the frontier for the federal agencies this time of the year for modeling the COVID-19 pandemic. So I'm very glad David is with us. And David, now it's time for you.
Thank you, Jianhong, for the introduction, and good afternoon, everyone. I'm going to share my screen. Okay, and I'm going to go this way. Okay, just confirming that you are seeing my screen. Yeah, okay. What I'm going to talk about this afternoon is an overview of wastewater-based modeling applied to COVID-19 surveillance at PHAC, the Public Health Agency of Canada. So we've been working on modeling the spread of SARS-CoV-2 using wastewater data for about a year and a half now. And this was initially the work with Champredon, and then the team grew a bit. And now we are, the people involved in wastewater modeling are here. Also, part of the acknowledgement is to recognize the work made by the lab. So the National Microbiology Laboratory in Winnipeg, they are the one who provide us with the wastewater data. So they are here. So this talk will be based on three main, will be articulated in three main points. I will talk about the data because I guess wastewater-based modeling is still relatively new, and there are a lot of uncertainties about the data and so on. But I think like within the last year and a half, we've learned a little bit on wastewater data that can be used for modeling. So, and then in the second part, I will talk about the model that we use. And then the last part will be how we use this model at PHAC to interpret the evolution of the SARS-CoV-2 spread in the population. Okay, so first I will start with an overview. Individuals that are infected with SARS-CoV-2 do not only shed with through the respiratory tract. Okay. They have also there is also fecal shedding happening. Sorry, I'm just going to move this. Okay. So yes, there is also fecal shedding happening. So what we all know is this part of the figure is that someone is infected, is going to infect other people, and other people are going to spread that into the population. And because we have a public health surveillance based on clinical cases, we just count the number of people that we think are infected by SARS-CoV-2, and then we end up with a time series of reported cases that is depicted here on the log scale. Okay, so but because there is also fecal shedding, happening during a SARS-CoV-2 infection, we can actually trace the coronavirus particle in the stools that are going, in the wastewater. So this is what I call the underground part of the modeling. So it's really to try to model what's happening to this particle in a relatively simple way, simplistic way, in the wastewater, in the pipes, right? And basically in the pipes, and then also interpret what. So you have these particles that are, shedded into the wastewater. Some samples are taken either at the wastewater treatment plant, either in a manhole in the street, if you want, at the neighborhood level, or they can also be sampled at the institution level, like, for example, a hospital, long-term care facility, and so on. So, but from wherever come the sample, it's sent to a laboratory, which is going to estimate the concentration of SARS-CoV-2 in that sample. Okay? And they do that using RT-qPCR. So it's a method which is very similar to the one that is used for respiratory samples. Okay? The only difference here is that the sample is not a nasopharyngeal swab. It's a sample of wastewater. And then, thanks to that, laboratory analysis, we end up with a time series of concentration of viral concentration in wastewater. Okay? So what I want to underline here is that now we have another data source that we can use on top of the more traditional clinical case counts. We have the viral concentration in wastewater. Now, wastewater is a strange environment. So, as I mentioned earlier here, the viral particles are making a journey in the sewage system, in the sewer. This journey is not as simple as what we think or we could imagine. So SARS-CoV-2 particles tend to attach to solid particles, and when you have solid particles in a flow, right, in a flow of liquid, some of them are going to sediment, and then maybe going to be recirculated. And the flow of water in the sewage is not constant, right? You have depending on human behavior, but also sometimes on environmental events like big rainfalls. So there is a component here that we call delayed plug flow that is that has to be modeled, but that we don't understand very well yet. So what are the main source of errors in the wastewater data that at least that we have identified so far? Well, there is first the natural decay of the RNA. Okay, we are looking for RNA in the wastewater sample, the coronavirus RNA, and by their nature, the wastewater samples are very active, and there is a high degree of biological activity that will cause the nature of the sample to change very rapidly. So that's one thing. For some sewer system, rainfall and snow melt can have an impact on the concentration that you will estimate at the end, for the viral concentration. Sedimentation and resuspension, this is what I've just talked about. This has an impact in the timing of when you measure the viral concentration. Okay, so between the time it's deposited by the infected individual and the time that it reaches, let's say, the wastewater treatment plant where we sample, there is a delay, and this delay is probably relatively complex. And this is what we try also to model in a very simplistic way, but this has to be taken into account. It's lab work at the end of the day. So you have human and technical errors, like for example, contamination of samples. the standard curve, which is tied to the RT-qPCR process, if you want, may also be a source of error. Like, how often the lab recalibrate standard curve may also be a source of error. So what I want to emphasize here is between the time that the viruses are shed by an infected individual in the wastewater, and when you have your final concentration that is given in a spreadsheet by the lab, this number that you read in the spreadsheet, may be impacted and is probably impacted by a lot of these errors, if not more, right? But so the wastewater data is inherently noisy. That's what we are going to see in later slides, and prone to some bias. So it's not the perfect data source. Okay, so on top of the potential errors that we may have and from the wastewater, there is a lack of standardized output. So when you ask labs around Canada or even in the world and ask them, what's the concentration of SARS-CoV-2 you have in the wastewater, you're unlikely to have the same units, unlike what you have with clinical surveillance, because with clinical surveillance, you just count people. So, we can say in Toronto today, we have 646 cases. Okay, fine, and then you can have 500 cases in Vancouver. So, and then you can normalize by the population of the city, and you can make comparison. What I've done here, I've just taken, it's been a while, like 2 months ago, but I've taken some screenshots from different websites that report the wastewater concentration in their cities. So you have Saskatoon's here you have somewhere in Quebec, this is Ottawa, and this is, I think, Vancouver. And when you look at what they publish, they say it's efficiency adjusted, and you don't really know what does this mean. Here in Quebec, it's raw and PMMOV normalized. Here it's just normalized in Ottawa. And in Vancouver, they provide you with the raw concentration. So my point here is that it's not standardized. Like even within Canada, which is just, you can think one country, and maybe the measures could be a bit more similar across cities in the same country. They are actually not. So this is something to bear in mind if you want to model with wastewater data, and especially if you want to compare several locations between one another. You have to be careful with that. Like what is the unit you are dealing with? Okay, so now I'm going to move on to the model. The model that we use at PHAC. So it's really a standard compartmental model, like your very vanilla SEIR model. I'm not going to go into too much details about the model. It's been published. At least the first version has been published. It's in Epidemic, and you have the link here, and I will circulate the slides after this presentation. But in a nutshell, it's you have susceptible, exposed. We have different state of infectiousness, so asymptomatic, symptomatic, and the symptomatic that are going to end up in hospital. We have vaccination in the model, so we can take into account the number of vaccinated individuals. And we have also, in an indirect way, through time-dependent parameters, we have also the different variants that are represented in the model. So really nothing new. Like you have like dozens of these model already out there for COVID and other disease. The difference is that we explicitly model a fecal shedding by the infectious individual. Okay, so all these infectious individuals are explicitly shedding in, if you want, a compartment which model the wastewater. Okay, so these are orange dashed arrows here. This compartment Z is to reflect the fact that after being infectious, individuals are still shedding viral particle, like SARS-CoV-2 particle in their stools for, I mean, the clinical studies have shown that you can detect SARS-CoV-2 RNA in stools for about 3 weeks, 3 to 4 weeks after symptoms onset. So it's quite a long time. But by then we know they are not infectious anymore. So we have if you want, the amount of particles that are shedded in the wastewater. And then we segregate what is shedded and what we measure at the sampling site. Okay, so we take into account the decay and the delay of the concentration of SARS-CoV-2 particle in the wastewater. This model is implemented in an R package that we call WEM for wastewater-based epidemic model. It's available on GitHub. It's here. You can download it. And what you download is the one we are using right now. We try to document it as best as we can. So the documentation is a better reflection of what was first published, because the model has evolved a little bit with time. Yeah, so that's the model. Now I'm going to go a little bit more into the details of what's new with this model. That is the wastewater model, like the fecal shedding model. So how do individuals shed into this wastewater? So it's a very simple way. We just count the number of people who are in these various compartments, infectious compartments, and we just say that they shed a proportional amount of their population in that compartment. So this is how it's mathematically represented. And W star is what is shedded that's deposited into the wastewater. It's not yet what we are going to measure. We have a fudge parameter, which is very convenient and which somehow reflect our lack of knowledge of exactly how many particles are going to make their way in the wastewater. So this is just a scaling parameter here, but I just want to highlight the fact that there is a lot of unknown, and this parameter is for now unknown. It's just fitted to the data. So the various compartments shed into the wastewater, and how it's done. So it's done with a time-dependent way. So what I mean by that, and I didn't mention that earlier, is that those compartments here, there's not one, but there are several. Like we have NA, A compartment, and II compartments. The reason why we do that, well, it's just to apply the usual trick, right? To have some kind of a gamma distribution for the length of stay in the infectious compartment. So that's one of the reasons why we do that. But now, having those compartments is also very convenient for us to have this different. So what we do is we somehow slice time when someone is infectious into, let's say, N compartment, or let's say 10. And why that's convenient for fecal shedding? Because we have clinical studies that have estimated the viral concentration in stools as a function of time since infection. So you really have this kind of profile, which is more or less similar to the viral concentration in respiratory samples, but not quite the same. So we have this information, we have the data for the viral concentration in stools. And that's really key in our model, right? So what we do is that when we have, so let's say, for the sake of the example, that someone is infectious for 10 days. And we are going to split the infectious compartment into 10 sub-compartments, so I1, I2, I10. And for each compartment, we are going to somehow map the distribution of this viral concentration as a function of time to those compartments here. So that will allow each individual that are in their first day of infectiousness, second day and third day, to shed an amount that is consistent with what's been observed clinically. So that's how we do that. So it's very simple, right? I mean, we just need to have this data from clinical studies. Okay, so now as a reminder, right? W star is the amount deposited in wastewater. It's not yet the one that we are going to measure. And to take into account what I've mentioned earlier, the fact that the journey of the viral particle in the wastewater is not like a smooth sailing through the pipes. It's probably affected by the turbulence in the pipe. So what we do, we model with a very simplistic. So we went into the literature of all this hydrodynamics, physics, and so on. And it's really not my expertise. Shokufe, who's not here today, but she was the one who really dive into this literature and came up with the formulation of how we could model that in a relatively simple way. And why we want to model that in a simple way, it's because we really don't have a lot of data to support whatever modeling assumptions we're going to make. So we just said, let's make things simple, at least for now. So that's the viral concentration that is at the sampling location at time t, and we model the decay of the viral RNA in wastewater. So this has been measured even for SARS-CoV-2. So we have a fairly good estimate. I wouldn't say good, but we have an estimate for kappa here for the rate of decay for viral RNA for SARS-CoV-2 in a typical wastewater environment. Now, this is to simulate the fact that, so I tried to depict that here. I'm not sure if it's really clear, but you can imagine that the SARS-CoV-2 particles are going to be spiked into the wastewater. So they are going to be dumped at one time, at what moment in time, for simplicity, right? For example, let's say when everybody flushes in the morning, right? So you're going to have this spike of concentration that has been initially introduced in the wastewater, and then you have the wastewater is going to make its journey from whatever neighborhood to the wastewater treatment plant, and during this journey, the concentration. I mean, there's going to be some dilution, right? It's not going to be a clean slice of those stools that is going to travel from the point. It's like the special point where it's deposited to the wastewater treatment plant. So there is some kind of a diffusion here. So this is what it's meant to represent. And tau bar here is the average time that it takes from the location where the viral particles are deposited to where they are sampled. Okay. So now I move on to how we fit the model to the data. So just as a reminder, we have what I mean by the data is mostly those two time series, right? Clinical reported cases. This is what everyone has been using so far, and the wastewater the concentration in wastewater. So the way we do that, and again, I'm not going to go into the details, but just what was our approach? We wanted to be able to fit to the clinical data and or wastewater data. Okay? So, and it really depended on the at which time we talk about, like whether it was before Omicron or during Omicron or after Omicron. Before Omicron, let's say we didn't have like a lot of experience with wastewater. So wastewater was more here to somehow support or augment the clinical data. After the Omicron wave, it's another story. Maybe we just want to look mostly at wastewater data. So we have those data, and the way we fit that, we use an approximate Bayesian computation algorithm. It's not efficient. The advantage is very simple to implement. So that's the main reason why it's been implemented, especially early in the development where we didn't have a lot of resources to do the work. It's relatively robust. I mean, you know what you put in, and robust, I would say transparent. Like your assumptions are relatively clear, especially the weaknesses of the algorithm are relatively clear, at least to me. So yeah, and it also provides some kind of a Bayesian framework, especially the posterior distributions that I like to work with. So the lack of efficiency of this algorithm is somehow compensated by the fact that we provide very informative priors when we are what I call in production environments. So I will show that later, but every week we produce some model output from WEM, and so this is what I call a production environment. This model runs at least every week, and so for that we provide informative priors. We are not really in what can I say, in the state of mind where we don't know anything. We give a uniform distribution and we just see what it is. After a year and a half running that for every week, we have a good idea of what should be the prior. So we just take advantage of that. And so that means that it's relatively efficient in the sense that it's fast, and that's also important for us that this fitting algorithm is fast. It takes about 10 minutes per sampling sites. And we have 20 sampling sites, around 20 sampling sites. So within 3 hours, our fit is done. On the relatively small resources, it's actually run on laptop, a powerful laptop, which has 16 cores. So yeah, here you go. Okay, so what we can do with this model and this fitting algorithm is, as I mentioned earlier, so we have the data on one hand, and the data are either clinical data or wastewater data. So the clinical data are reported cases, and this is the SARS-CoV-2 concentration in wastewater. You can imagine that we have switches in the model that can allow us to turn off and on the input of data. So if we want, we can only fit the model based on wastewater data. Or alternatively, we can fit the model only on clinical data, reported cases. Or if we switch them both on, we can fit WEM on both the reported cases, the clinical reported cases, and the wastewater data. The type of output that we produce are the very standard output, like short-term forecast estimation, like estimates of the effective reproduction number R. This is grayed out because the estimates of the incidence and prevalence are a little bit more tricky to provide with some confidence. But I put them here because I touch on that in a few slides. Hospitalized cases are also difficult for us to obtain. So what maybe I should have emphasized earlier is that when we talk about wastewater data, these data are at the municipal level, okay? Or even worse, or even like a lower level, like the neighborhood level. And if we want to somehow work or compare with the clinical surveillance, you need to have clinical data that are at the same spatial resolution that your wastewater data. And for us, so remember I work at the Public Health Agency of Canada, so that's a federal agency. We have some difficulties to access municipal data. So reported cases, when it's on their website, we just take them, and most of the cities we work with are doing a great job at publishing their reported cases, their clinical reported cases. But for hospitalization, it's much more difficult. So that's why it's grayed out. But that's a possibility. Okay, so how do we use this model at PHAC and this modeling framework and all this data? So we have a wastewater surveillance program that has been set up at the beginning of or shortly after the start of the pandemic. So what you see here is a map of Canada, and each blue point is a location where the National Microbiology Labs, which is part of PHAC, has some wastewater sampling activity. Okay, so you see it's relatively well distributed. But for the modeling, we focus on 5 large cities: Vancouver, Edmonton, Toronto, Montreal, and Halifax. And why do we focus on those? Well, first, as you saw, right, we have a compartmental model driven by ordinary differential equations, ODEs, and that's more adapted to large populations. So if we take a small community somewhere in Yukon, where there are only 1,000 people or even less, it's not the best modeling framework to do that. So, and furthermore, the advantage of working with large populations is that the stochastic noise tends to be smoothed out. So these are the 5 locations that we focus on the modeling side. And furthermore, again, as a federal agency, we are also interested to know, what's going on nationwide, right? So having sampling in the largest city centers is probably a good way to have an idea of what's going on at the national level. So if I zoom in these 5 locations, so in those large cities, usually what you have more than one wastewater treatment plant, and that's at the wastewater treatment plant that we take the wastewater sample. So, for example, in Vancouver, you have actually it's not 4 but 5. It's a typo here. You have 5 wastewater treatment plants. In Toronto, you have 4. 4 that we focus on. In Montreal, 2, and Halifax, 3. And when you look at their catchment area, the catchment areas of the wastewater treatment plant, the population coverage is relatively good. So for the city, at the city level. Okay, so in Vancouver, we think we have about 98% of the population that is sampled through wastewater surveillance. So this is the data we work with. For these, so actually I said 5, but now we have 6 cities, and I wanted to show the latest data, so that's why Winnipeg has popped up here. But initially, Winnipeg was not present in our analysis. So what I'm showing here is, so the top panel, the black curves are the clinical reported cases. It's on the log scale for each city. And the bottom panels are the wastewater, the viral concentration in wastewater, the SARS-CoV-2 concentration in wastewater, also on the log scale, and the unit is in terms of gene copies per milliliter. What I want to emphasize here is how similar they are, right? Now we have nearly 2 years of data behind us that shows that, when you look at the peaks and so on, and the drought, they have, you can see that wastewater, the wastewater signal is relative, like mirrors more or less what we've seen on the clinical side, especially when the clinical surveillance was really intense. Okay, so let's say in 2020, 2021. Of course, wastewater data is noisy, and this is what I mentioned earlier, like all the source of errors and noise that we can have. So it's a noisy time series, probably noisier than what you see when you have a very good clinical surveillance. But here it is, right? I mean, it's relatively good. So now I'm going to show you how we dealt with the Omicron wave when it was unfolding. So you remember this slide, what I showed you, right? We have the data on one hand, we have our WEM, the wastewater-based epidemic model, and we have some outputs that we want to generate thanks to this model, like typically short-term forecast or some kind of inferences that we can do. So what we did, we used our wastewater-based epidemic model, so WEM, twice. The first time, we just used it on the reported cases. And then, so we switched on reported cases and switched off the wastewater data. And then we do the opposite. Then we did, we switch on this wastewater data and switch off the reported cases. So in these two scenarios, we have one scenario where the model is fully informed by clinical data, and the other scenario where the model is fully informed by wastewater data. So this is illustrated here for the city of Toronto. So what we have here is the black line are the reported cases by the city of Toronto. The pink line is the model that is fitted to the clinical data on to the black line. So here what we show is just that it's fitting the time series. So that's okay. Now, this middle panel here that you have is the wastewater concentration in Toronto. And this is what we use to fit the model. So we just only use this wastewater data to fit the model. And then ask the model, okay, back calculate what should have been the reported cases if we were just to look at the wastewater data stream. And this is the blue line that you see here. Okay? So this blue line is what I call they are not reported, right? But the reportable cases, the one that should have been reported if you just believe what you see in the wastewater. And you see there is a discrepancy, right? And so this is the Omicron wave, early January 2020. And what the story that the wastewater data tells us is that you have much more infections going on in the community than what the clinical reporting tells you. The vertical dotted line here that you see, the gray one, is the time where the testing guidelines have changed in Toronto. And it coincides more or less with when the two, if you want, the curves are diverged, right? So that allows us to infer somehow that there was an underreporting, and we could try to quantify this underreporting, maybe around 80% underreporting in this city at that point in time. And then as the infections were like decreased, then the underreporting also decreased, right? And the wastewater and the clinical surveillance were much more in line with one another. So at the time, it allowed us, well, to estimate the underreporting, also to confirm that we have passed the peak of infection, okay? Because at that time, we knew that everyone knew that clinical surveillance was not really reliable and was showing a decrease, but this decrease was was caused probably more because of the testing guidelines have been changed. Another output that we looked at with the model was the effective reproduction number. Again, one which is inferred only from wastewater data, and the one which is inferred only based on clinical surveillance. And then we did that not only for Toronto, the one I just shown in the previous slide, but for all the 5 cities. At the time, we only had 5 cities, early February. And what we saw was like that not all the cities had the same experience in terms of what we think was the underreporting, the clinical underreporting that was going on. For example, in Montreal, at the time, we thought that, clinical surveillance was more or less in line with what we could see from wastewater, which was not the case, for example, for Toronto and Vancouver. Okay. Then we aggregate all our inferences, so all those blue curves that you see here. So what we think is really going on based on wastewater, we aggregate that at the national level. So the aggregation is questionable, right? I mean, does it really make sense to aggregate wastewater from Vancouver, Edmonton, Halifax, and so on? But still, I mean, it's just to give us an idea of what's the state of the epidemic at the nation, at the national scale. So these were the reported cases for these cities, and so that was the sum of the reported cases, and here is the sum of the wastewater-based forecast of the reportable cases from those 5 cities. Okay, so here again we see like a lot of underreporting in early January. So as I mentioned earlier, we continue to do that. So we do this weekly monitoring since late 2021. So now these are the same figures that I showed earlier here, but those were as of early February. I just wanted to show you that what other inferences we can do as we continue our analysis. So, for example, here in Vancouver and some other cities, we continue to see this significant underreporting from many cities in Canada. Montreal seems to be, I mean, according to our model, and again, there are a lot of caveats, but according to our model, Montreal seems to, I mean, the clinical surveillance in Montreal seems to be in line with what we see in wastewater. So maybe, they are maybe keeping more track, they're better at keeping track of what's going on from a clinical point of view. Yeah. So just to wrap up, so wastewater data has obviously its own biases and uncertainty. It's site-specific. Okay, so it's really we are really modeling at the municipal level, and sometimes even at the neighborhood level, because the wastewater treatment plant are going to cover just a neighborhood. So that's a difficulty of wastewater-based modeling. But when you combine that with clinical surveillance or other data sources that you can have, hospitalization, seroprevalence, it's another data source that allow to do a better triangulation of the state of the epidemic in the communities. One of the problems is that it's still a new field, and so there is not a lot of standardization in terms of output, even in terms of laboratory methods and so on. So we have to be careful when we want to interpret the data. I think what I've tried to show during this talk is that combining a mathematical model, like a mathematical representation of what we think is going on, both in the population, at the population level, and also, underground, like in the sewer system, so combine that with wastewater-based surveillance, allow us to do a lot of inferences, like, to back calculate what should be the incidence or the prevalence or what should have been reported and so on. And again, like the same thing as the triangulation, right? It's to dissipate the fog of war that we had during especially during the first Omicron wave. The fact that it's, again, I mean, it's just reiterate the fact that it's a municipal level modeling. So having municipal level data may be a challenge, not only for us as a federal agency, but in general. I think one weakness of what I've presented here is our current knowledge of the fecal shedding is very limited. So okay, I'm going to go back to this curve here. When I said that clinical studies are providing us with data about that, that's true. Unfortunately, those clinical studies are usually very small. Like, you are talking about a dozen of patients that are followed. And moreover, most of the patients that are followed after symptom onset. So we are more or less blind to what occurs in terms of fecal shedding before the symptoms appear. Okay, so that's a problem. And so, sorry, I'm just going back to where I was. Yes, so this is, I guess, one of the weaknesses that we have. Another weakness is what's going on in the sewer system, like, this plug flow model, like the very simplistic model that I showed you. So this one here, okay. I mean, yes, this one. This is ridiculously simple. Right? But so we tried to team up with academics that are actually not in public health or epidemics, but that have spent decades looking at what's going on in the sewer system and try to better model that. So that's for next step. And so, yes, so in terms of next steps, yes, so it's to improve our model. We are also scaling up to more sampling sites such that our surveillance is more exhaustive in terms of population. We also try to integrate the sequencing information into this model, but that's actually not in this model, but we have like other models that are trying to integrate sequencing from wastewater to better inform, what kind of variants are circulating, and then once we know the variants that are circulating, how should we adjust our transmission rates or the waning immunity and so on. And then, last but not least, we are going to apply that to other pathogens. So the NML is monitoring the SARS-CoV-2 concentration in wastewater, but they have started like a few months ago to monitor influenza and RSV. So the idea is the idea is to expand this model or make other models, maybe simpler models, we will see, to track other respiratory infections in wastewater. And to conclude, I just put these two links here. So this is the link to the dashboard. So the dashboard, the PHAC dashboard, which has the data that you saw here. So if you want, you can have exactly this, more or less exactly the same data that I have access to. Okay, if you want to model yourself. So this is the link to the dashboard. It's updated twice a week, so it's fairly updated. And then the last link is about the wastewater surveillance program at PHAC, if you want more details. And that's it. So this is my contact information. I put that up if there are any students in the audience that are interested in working with us. You can contact me. Okay, I think I'm done. And if you have any questions.
Thank you so much, David. We're actually going to hand over to Gabriel Frankston, who is online. That was excellent. And I can't. Very interesting, and I know there's so many questions. Poor Gabrielle has been monitoring the chat, so she's going to do her best to try and summarize what's been said. But just to introduce Gabrielle, she's She's being supervised by Dr. Amy Greer, which some of you will know, and she's a PhD candidate at the University of Guelph, and she's working on the modeling of infectious diseases. So I'm just going to hand over to Gabrielle, and she's going to moderate the questions now.
Thanks, Sarah. David, that was a fantastic talk. It was really interesting. I've been curious about wastewater for quite some time now, and it was a really good talk to orient us to this type of surveillance. The chat has been very active during the talk, and so what I was thinking is, I mean, there are some straight questions at the bottom of the chat, but I think there are a couple of there were a couple of discussions earlier on that maybe I'll just summarize for you. Maybe if you wanted to comment, then that would be fantastic. So the first one was there was a question about somebody was wondering why hospitalized cases are not shedding in your model diagram. So going back to the shedding discussion from slide 9. So in the flow diagram, why are hospitalized cases not shedding? And there was quite a discussion about it. You know, queries, you know, is the H compartment such a small fraction of the infectious population that it may not matter very much? Kind of gets lost in all the noise that you're talking about in the data. You know, how much, if at all, would this affect your outcome? With others commenting that the effect would be pretty minimal. So it wouldn't affect the outcome very much.
Yeah, yes, and yeah, sorry, I should have mentioned that when I was presenting. So we made the simplifying assumption that people who are hospitalized are not contributing to the to shedding in wastewater. Why? Well, some of them are bedridden, so you know, it's so much for contributing in wastewater. And we thought that even if, so they are definitely, I mean, if you were to measure viral concentration in stools of hospitalized people, they do shed, right? I mean, they shed for sure, because actually the studies that I mentioned, most of them look at hospitalized individuals. So they do shed. We made the simplifying assumption that we are not going to bother with that. Because when you look at any point in time, the fraction of hospitalized individuals in the population is very small. And furthermore, if you take into account that, I don't know, let's say a third of them are in ICUs, then they don't contribute to the wastewater. So yeah, that's what we did. But we kept it here, sorry, maybe we kept it here because we were hopeful to have hospitalization data, and then that we could fit our model to hospitalization data. We haven't quite managed, as I mentioned like several times during the talk, hospitalization data is something which is a bit difficult for us to have. So, but it's there, like for death, if you want. You know? So those two compartments were here to help the model to be fitted.
Great, thank you. The next little discussion, it was very active. The next little discussion was just a comment actually that the Toronto plants receive and treat wastewater from other health regions, so like York and Durham regions. So, but the results in your model appear to be Toronto specific. And does the fact that Toronto wastewater plants process wastewater from other regions impact your results? Or is there some sample? Is the sampling at the wastewater level done such that those regions are?
Okay, so it's good that you mentioned Toronto because this is the only map I have on the slide. So this is Toronto, and each red perimeter, I don't know how to call that, represent the catchment area of a wastewater treatment plant. So I'm not sure if I understood correctly the question, but we don't, when we have samples from Toronto from let's say Ashbridge Bay, we know that this sample cover this population here. right? I mean, I don't know exactly yet. So this one here. Okay, this is the area, this is the community that contributed to the sample that we received from Ashbridge Bay. So, yeah, I think it answers the question, or maybe I didn't understand the question, I'm not sure.
Yeah, I'm not sure I understood the question either. I was trying to summarize a different discussion when the question was asked. I think it was just a comment.
If I could jump in, my understanding is York Region and Durham Region both have to siphon off their wastewater to get York Region and Durham Region estimates, because I'm positive that Durham Region is processed by Ashbridge's Bay. I'm not sure which of the Toronto ones. So David, these maps may be correct for the Toronto population, but I don't think they're totally complete for the watershed, if you will, that each of the treatment plants in Toronto actually serves.
Yes, okay. So yes, we are aware, and I think, I mean, and I'm not 100% sure, but the link with the other regions, isn't it like some kind of an overflow or something like that?
No, I don't think it's overflow. I think it's their main treatment plant.
Okay. Okay. But for most of the wastewater plant that we have, in Toronto may not be the best example, but the catchment area is relatively well defined. But yeah, so maybe just to answer your question, if there are some other communities that are shedding into the and being treated by this wastewater treatment plant, then that will affect, yes, what we do. Yeah.
Okay, thank you. The next question is whether wastewater surveillance has the same delay in reporting as that in reported case surveillance, or what the difference might be.
Yeah. So it depends on how the process is made. So here at PHAC, we are at a disadvantage somehow, because the way it works, it's that samples are collected in these cities, and they are all shipped back to Winnipeg, where the NML is, and all processed together. The advantage of doing that is that it's the one lab, one team that does all those samples. So, you know, it kind of makes sense to compare the different concentrations that you see across all those cities. The problem is that it takes time to ship those samples from all those cities to Winnipeg. And so we have about, it depends, but 5 to 10 days delay in shipment. It depends on many factors. And that's a disadvantage compared to, for example, the people in Ottawa. So in Ottawa, so we don't cover Ottawa, but Doug Manuel, who's leading the wastewater surveillance over there, what they have is that they can sample the wastewater in the morning, have it sent in the lab, let's say in the afternoon. They do their qPCR, and the next day they have their viral concentration. So that allows wastewater-based surveillance to be much more reactive when you don't have this kind of delay that we have. And then the reporting is, so once you have the viral concentration measured in wastewater, then there are a few checks that are being done, and then it takes whatever it takes to report it. So what I would say is at PHAC, our reporting lag is uncomfortably long, in the sense that we are at least 10 days after the sampling date, like the collection date. So that's a little bit annoying. If you are in a situation like Ottawa, for example, where everything is is on the same site, like you sample on the same site, you do your lab analysis on the same site, and you report from the same site, then you would have I would say between 2 and 3 days delay between collection and reporting. Now, what do you collect is another question, because I mentioned that there is and I'm sorry, it's just something I stole on the web because I didn't manage to find what I wanted, and I didn't have the time to do it myself. But what happens is, what we believe happens is that, so SARS-CoV-2 is clinging to and attaches to solid particles in the wastewater, right? Those solid particles, there are various sizes, but the size of the solid particles are the time it's going to take them to sediment is going to be different. So what I mean by that is, imagine you shed like an amount of SARS-CoV-2 in the wastewater. This SARS-CoV-2 is attached to solids. There is going to be some kind of a distribution, right? Like, it's not all the particles are going to make their way to the wastewater treatment plant at the same time. But even worse than that, some are going to sediment, and based on the flow in the sewer system, they are going to be like the turbulence, they are going to recirculate. So you may end up with SARS-CoV-2 RNA, and we don't need like a live virus. Like, we just target like the N1 or the N2 genes of the genome of the virus. So you may end up with a fraction, and we don't really know if it's a significant one or not, that is going to be a few days old because that's been recirculated in the wastewater, and that's what you collect at the wastewater treatment plant. In our model, we have some kind of a distribution for the delay, and the average is around 1 to 2 days. It depends. I mean, we feed that to the data, but we don't have any data to do it, so it's kind of a how can I say? It's not really fitted. It's just to acknowledge the fact that the delay is stochastic. So it's a long answer to a short question, but the reporting delay in wastewater, you have to look at several layers, right? So there is the delay that the viral particles are going to take to make their way from wherever they were deposited to wherever we sampled them. And then there is the lab process time. And then there is the actual just reporting time, like the time it takes to put that on a website or something like that.
So it's not necessarily an early warning
system. It's not necessarily
it's
an early warning. Yeah, right. So I dissent a lot with the wastewater community, in the sense that it can be an early warning. Okay, so for example, let's say, and again, I just pick Ottawa because it's the first example I have in mind, but like a place like Ottawa can be an early warning, but I'm not convinced it's always early warning, wastewater. I think the strength of wastewater is what we are seeing now, is that when clinical surveillance is minimal, and wastewater can still give you a relatively good picture of the state of the epidemic in a community. Mm-hmm. Whether you are in the 8th wave or 12th wave or something like that. But the timing it's much more difficult to understand, how soon we see the signal in wastewater.
Mm-hmm. So that actually feeds nicely into the next question in the chat. Is it the trends in the metrics or the absolute values that are most important for transmission surveillance and forecasting?
Yes, so I would say, and I'm showing this because I guess I'm going to contradict myself. So the trends are important. This is what I said. For example, when you look at the clinical surveillance, the black curve in Vancouver, and just take Vancouver as an example, we can clearly see that there is a second wave, a marked second wave that was happening starting in April. Now, I think what's interesting is not only the trend, but to know what kind of size, like, what was the prevalence like in the community for this second wave that has been completely missed by, or not only missed by the clinical surveillance system. If you believe what the model is giving you, and I wouldn't believe it like 100%, but that was probably like half the size of the early Omicron, the first Omicron wave, like early January. If you believe what the model says, the problem is. So I think the absolute number is important because it allows us to assess the amplitude of prevalence, like the level of prevalence in the community. Now, this relies, like, to be able to compare this peak to this peak. This means that I know, or like we know, that shedding, like fecal shedding from all those people infected at that time and those people declaring that infected at the time, we know the difference. Like we know, are they shedding the same? Are they shedding less or more? And I'm saying that because maybe like in this wave, you had, I don't know, maybe like a good proportion of people who were already infected, either by the previous Omicron wave or by the Delta wave before, or the Alpha wave or whatever. And maybe they are not shedding as much, like the fecal shedding is maybe different. What we have assumed in the model is that it's the same. So it's probably not the same, but there is no studies, or to our knowledge, there is no studies that try to assess the difference in fecal shedding between someone who's been infected twice or the first time, someone who's vaccinated, who has like several like boosters, the difference between being of fecal shedding between being infected by Omicron, BA1 or BA5, all that we don't know. So we would like to think that we know. That's what we do here when we present this curve. But the truth is that we don't know. Maybe the reportable cases, like this blue line, is much higher. Like maybe the wave was much higher in April than in January, because people were shedding less, because they were somehow, their immune system was more able to deal with the infection.
Mm-hmm.
David, what I've been led to believe is that BA2 is more transmissible because people infected with it have a higher viral load. So what many people have said is that the wastewater spike for wave 6, the BA2 wave, should almost be cut in half, because each of those infected people are contributing on average much more viral material to the wastewater than the people in wave 5 that were largely infected by BA1.
Yeah, I agree. That's if, and as long as I don't see the data in stools, it's we don't know. So and it's not clear how respiratory sample correlate with stool sample.
Yeah, I think the other is, as far as monitoring, we've also found, because of the tightening in testing, modeling against hospitalizations, we always know that some proportion of individuals who get infected are going to be sick enough to need to present to hospital. So again, following the trends up and down in hospitalization, like I work with the city of Hamilton, and quite frankly, even with the decreased testing that happened in January, we can still track cases from a trend perspective. And that was really the origin of my question, because I don't think absolute value provides a lot of value, but I think trends over time, certainly from a management of the pandemic, is really important. And I think people have wrongly discounted tracking cases, like all of a sudden tracking cases is no good. Even when we had open testing, we know that there was a large proportion of individuals, either half of them or even many more, that weren't coming for testing. They were just getting sick or they were asymptomatic. And from a clinical perspective, we never were learning about them.
The next question in the chat is about the presence of different symptoms. So for example, with Omicron, there's been reports of more gastrointestinal illness. And so the question was, with the greater presence of diarrhea among other symptoms for Omicron, would that in fact shedding and then lead to an overestimation of the so-called reportable cases, or the reportable wastewater, I guess, would it increase the wastewater value if the model was fit using pre-fitted parameters for Delta, for example?
Yeah, so here again, I based what we do with the model on the literature, and unfortunately there is not a lot of literature on that. My understanding, based on the very few papers that have looked into that, is that so what is it? So the concentration doesn't correlate with the symptoms. So if you have patients who have diarrhea, the concentration did not seem to be affected too much by the fact that they have diarrhea.
Okay.
But again, it's based on like a handful of cases, so it's not really. Yeah. And by the way, because we are also looking at influenza, there were some studies also on influenza based on that, like whether you see more viruses in stools, influenza viruses in stools, from patients that have diarrhea or not, and they didn't see difference. But again, it's based on, I don't remember exactly, but maybe like a dozen of cases or something like that. So, but yeah. Okay. So it's difficult to know.
Thank you. Yeah. We're about 10 minutes past 2. Sarah, did you like to keep going, or would you prefer that we end it there? And as Jin Hong says, we should pick this up again and update it in August, because it's really fascinating.
Yeah, I mean, we don't mind it running over. I mean, if there's a lively conversation, that's fine. Jin Hong, you agree? Because we can record it and people can, you know, who can't stay. But I do agree that we should meet again. So Jin Hong, what do you think?
I think discussion can continue. I noticed there are some participants not normally coming to the field colloquium, so it's a good opportunity for them to interact with David.
Okay, sounds good. David, you're still in the hot seat.
I assume David is available.
Yeah. Yeah. David, are you okay to continue?
Yeah, for 15 more minutes, it's okay. Yes, until 2:30.
Okay, sure. Okay, perfect. Okay, so the next question is, shedding concentration depends on time since infection, but in the slides, people in the Z compartment will have to experience the up and then down shedding concentration process again. Is the assumption reasonable?
So let me just process the question. So can you repeat the question, please?
Yeah, so I'm just reading it word for word. Shedding concentration depends on time section, but in your slides, people in the Z compartment will have to experience the up and then down shedding concentration process again. Is the assumption reasonable?
No, no, that's not reasonable, and that's wrong because, sorry, here we don't have the same lambdas. So for Z, it's different. Yeah, sorry about that.
Okay.
So they won't have the same profile. Okay. We have the same profile for these guys, J, I, and A, but Z is different. So,
yeah. Okay. All right. Thank you. I think you touched on this a little bit. Are the results of the model influenced by the shedding concentration among back versus vaccinated, or some people who have higher shedding concentration than others? I think you did touch on this a little bit already.
So can you repeat, please? I think you
yeah. Would the model results be influenced by shedding concentration in vaccinated versus unvaccinated people, or people with higher shedding concentration than others?
So we didn't we didn't make a difference between individuals who were previously vaccinated or not. Again, because we don't have data.
Right.
So we just make the simple assumption that it's the same, which may be wrong.
Okay. The next question, can modeling take the place of better standardization methods?
Yes, yeah, exactly. So I think that was somehow what I meant here in one of my final points, is coupling a model with the wastewater surveillance data somehow normalize everything, because inside the model you can calculate back whatever you want, like incidence and so on. The only problem is that, and I think that's what I've repeated like several times, is that there are a lot of unknowns in between. So typically, what's the profile of fecal shedding? Like, do vaccinated individuals shed more or less than unvaccinated individuals, and so on. But that's when we present these slides at to upper management and so on, that's easy to understand. I think that's easy to understand. That's what has been reported, what should have been reported. Okay, with all all the weakness of the model, and the absolute values may be wrong or even completely off, right? But this is the best we can do right now. And that's basically what you are showing is an incidence curve. Whatever was the wastewater data made from, what I mean is the labs have different methodologies, and you may or may not want to normalize this signal by the population, by the flow of the wastewater, by many things. But once you've taken that into account into your model, then you can really translate that back to something that is more familiar, at least for epidemiologists or public health. So yes, definitely. I think that's one of the main goals of the model.
Yeah. Great. And I think this might actually be the last question. I'll have to take a scroll down a bit, but this question is, were you able to do any comparisons on earlier waves when clinical data were better? So this seems to be, you're presenting Omicron.
Yes.
Were you able to do any of this during certain like Delta or Alpha or?
Yeah. So we did that, and actually that's while we were developing the models, it was during the Alpha wave and the Delta wave. And as I showed here, I mean, it's difficult to eyeball that, but the data is more or less the same. So what we were doing, we were using both data, but what I meant is that the wastewater data at that time was not adding much, because the clinical surveillance was so good that the wastewater data was more or less mirroring what you could see on the clinical case. You may have some subtle differences that we maybe at the time now, with hindsight, we may have overinterpreted, or maybe there is, but it was basically the same. So adding wastewater data was, interesting, and may have provided some interesting insight from now and then. But it's definitely when Omicron came in that we saw the real added value of wastewater, typically doing this kind of
Yeah, I think this has been a fascinating discussion, David. Thank you so much. That was that was it for questions. That was a lot of questions, but clearly a very interesting and animated discussion. So thank you very much.
Okay.
Yeah, thank you so much, David. I don't think we've had that many questions one of our colleagues, so that was fantastic. Unfortunately, Jan Hong has had to leave to go run an in-person event at his lab, so he's not here to say farewell, but thank you so much. Gabrielle, good job. I could see you had your hands full with all the questions. David, it was absolutely fascinating, and I know everyone was really interested to know about it all, so thank you so much. And yes, we look forward to welcoming you back. Hopefully you'll accept our next invitation.
Thanks for the invitation. Bye.
Thanks, everyone. Bye.